So whenever a preterm is born, he is going through a lot of emergencies. Respiratory emergency is there, resuscitation is there. You are thinking about neurological outcome. Then what we tend to forget is about the nutrition. The baby was was being well nutrited inside. Suddenly that nutritional source is cut off, and a nutritional emergency occurs. That we tend to forget. So what are the importance of, and why we have to be aggressive about the enteral part? I'm telling about the enteral nutrition. We tend to keep, previous practice was we tend to keep the baby NPO. Well, why should we go and aggressive regarding enteral nutrition?
Yes, you are correct, Dr. Nelby, that whenever a baby or a preterm baby is born, we are too much into the technical parts, like like Dr. Vishnu told about this volume guarantee ventilation, targeting tidal volumes, minute ventilation, PCO2 levels, PO2 levels, pH levels. So we usually tend to forget about the nutrition part. Usually some of the units keep them exclusively on this 5% dextrose or 10% dextrose and inotrophs, all those things. But what happens to a baby, especially a preterm baby is born, when the baby is inside the uterus, when it's inside the womb, he or she will be getting a lot of nutrients. So initial part, this is the first trimester, you know that there will be organogenesis. In the second part, second trimester, there will be organogenesis. Some of the nutrients will be transferred to the baby. And in the third trimester, it's mainly a somatic growth. The proteins, the minerals, the fat, everything is the somatic growth. The baby's size will come in the third trimester. So you are taking, when the preterm birth happens, actually it is a nutrition emergency. You are taking the baby out before the baby gets adequate protein and other fat supply to the body. So we can change the slide. So the next one is actually it is a dip in the nutrition. That's a dip, as we tell about this weaning of babies in 6 months, there will be a nutritional dip. So that, next slide, next. So likewise, there's a bit of malnutrition happens when the baby is born preterm. When the intrauterine live baby is getting a lot of nutrients, and we are suddenly taking out the baby, so it's actually a nutritional emergency. So preterm birth happens, then this, that gap can always, somewhat, you can fill the gap if you give this early aggressive enteral nutrition or parental nutrition. So, and there are a lot of problems for if you start this enteral nutrition on the day 1 for the baby, because the baby may be hemodynamically unstable, he will be in shock, sepsis or RDS or any other thing. So you may not be able to start this enteral nutrition in the initial, but still the hemodynamically stable, there is no other perforation or any other surgical emergencies are not there, still you can start trophic feeds. So that the concept is minimal enteral nutrition. So you can always start minimal enteral nutrition in a stable baby in the day 1 itself. So what is the concept of minimal enteral nutrition? It is not for this caloric supplementation. It is mainly for the gut maturation. The local enteric hormones will be released. The gut maturity will be accelerated. The duration, the time to full feeds will be less. The duration of NICU stay will be less. There are less chances for the baby develops chronic diseases like this CKD or chronic lung disease. So always, as the slide says, you can always start these trophic feeds within less than 24 hours. And always the preferred preferred milk is mother's own milk, which is not available. Always you can go for a pasteurized donor human milk, which only a few centers in Kerala is available. So still it is not there. The third choice is always a preterm formula. So if you start minimal enteral nutrition, and if the baby is less, how will you advance the feeds? So if the baby is less than 1 kg, always you can start with this 10 to 20 ml per kg per day of feeds. And for more older babies, you can start 20 to 30 ml per kg per day of feeds. In the 2 to 3 hours gap, you can start. And the same advancement, you can, if the baby is tolerating feeds, you can advance 10 to 20 or 30 to 35 ml per kg per day as you can advance. So as a dictum, these babies, usually these very preterm or moderate preterm babies will become full feeds in 6 to 7 days, and extreme premature babies usually become full feeds in 7 to 10 days. So that is the average thing. So exceptions can be there. So many of the times what the unit the protocol may be, something like that, before each and every feed, sister is used to aspirate. So something will come out, isn't it? So some milk will come out, some color change, so some light greenish things will come out. So those things are of no significance. So routine pre-feed aspirate, as previously recommended, is not recommended now. There is no use of doing that. And another thing is that, which was usually practiced, was the abdominal girth measurement, which is again of no use now. So what you can see is that the baby is becoming more clinically unstable, so becoming more apneic, vomiting is there, frankly bile stain vomiting is there, blood in stools is there, or blood in vomitus is there. In that case, okay, or the abdomen, you feel the abdomen and the abdomen is become tense or though. In that case, you can stop it, aspirate and see whether any color change or the is there, and do the things accordingly. Otherwise, there is no indication to do this routine, this OG aspiration or abdominal girth measurement. So yeah, yes.
This is a slide just to show the importance of enteral nutrition. If you see that side, those are microvilli. If you see that side, the epithelial cells are thinned out. That side shows the baby who is not fed. The epithelium is thinned out. The secretory enzymes are thinned out. The muscle wall is thinned out. But if you feed the baby, this gut thickening occurs, so that bacteria would translocate inside, and this non-fed babies are highly prone for late onset sepsis. That is another importance of being aggressive regarding nutrition. So practically, two things I want to highlight is, there is a common practice that preterm baby, mother's milk is not there. So we are worried about NEC. So we have to give, our practical option is only preterm formula. So we won't feed the baby. We'll keep the baby NPO on IV fluid for long term. You are inviting infection. You are creating problem for the baby. So never wait for that. Start by 24 hours, start feeds. Second thing is,
by doing that, definitely your duration of hospital stay is going to be longer. So in that case, again the risk of sepsis is more. Again the risk of other complications are
there. Second thing is, Murali was mentioning this stopping feed for simple reason. Some aspirate is there. Always, whenever there is doubt, just feel the abdomen. If the abdomen is soft or not. If that NEC feel is there or not. If the abdomen is soft, whatever the reason is, whatever aspirate is there, grade up the feed. Reach the feed by 5 to 6 days. Your baby is going to go home, definitely.
Especially those, including my unit, some of the staff are the tendency to put the syringe and aspirate through the OG tube. So they have the irresistible urge to do that before each feed. So even after repeatedly telling them no need, still they will do. So some of them will pull out the mucosa also. Okay.
So we have discussed about this enteral nutrition, but we don't have to forget about parenteral nutrition. If the baby is less than, say, 1.5 kg or 32 week, we may have to give for parenteral nutrition. Can you tell about parenteral nutrition, Dr. Binu?
So now I think most of our units are into the parenteral nutrition practice. Now there are two ways of giving parenteral nutrition. Like the earlier times, we used to give the slow grading of amino acid and SMOF, lipid, 1 gram per kg, slowly grade by 0.5 grams per day, and by the end of 1 week they will reach around 3 to 4 grams per day. Now it's more aggressive, like the SMOF is started around 3 grams to 3.5 grams on day 1, and the amino acids are also like that, and then continue that, and then slowly, once the enteral nutrition picks up, stop the parenteral nutrition. Now personally I would prefer the aggressive parenteral nutrition, because the purpose of giving parenteral nutrition is to give calories in the first week when we are not able to feed the baby much. As we all know, the babies need around 80 to 90 kilocalories, including protein and non-protein calories, to maintain growth in the first few days. So by giving minimal enteral nutrition or giving dextrose or the slow grading of TPN, it won't even reach around 30% of the recommended. So if we give the TPN at 3 and 3 grams, we may be able to reach at least 80% of the necessary energy. So that is what is important. And if you give more of energy, what is seen is it's easier to extubate the child. Like some babies have a lot of muscle catabolism and muscle breakdown. When I'm talking about extreme preterms, that once they are ventilated and if you don't give enough nutrition, we'll be stuck on the ventilator because baby will not be taking effective breaths. So these all things come to the view. So that's what my take is, to like go for aggressive parenteral nutrition, monitor the aspects. It's not that dangerous. I've hardly seen any side effect of aggressive TP in so many years. So I think that should be the norm.
Thank you, Dr. Binu. Now one question to the audience, basically for the PGs. What is the intervention which has saved maximum number of preterm babies? Ventilation, surfactant, what is the, or anything else? Can anyone tell? What is your opinion? Anything? What is the intervention which has saved maximum number of babies? Dr. Binu will be telling, and Dr. Deena will be telling about it. That is the prevention of infection. Very simple step, hand washing. So I think Dr. Deena can just highlight the importance. That is the most important thing, part of this discussion.
So we all know that we all want that our baby should not have sepsis, especially hospital-acquired sepsis. That is the most important thing that we want to prevent. And for that, hand hygiene is the most important and the only step, I would say. So hand washing should be done on entering the NICU when you have visibly soiled hands, or after you have examined an infected patient, or even after examining 3 to 4 patients with hand rub. I would suggest that you go and do the hand washing. So hand washing should ideally be done for 40 to 60 seconds. And hand rub, the WHO recommends that should be done for 20 to 30 seconds. So you should have, for practical purposes, there should be posters in the hand washing areas where the people will see, and there should be warnings everywhere. And periodically there should be a surveillance by your nursing in charge to see that whether the 5 moments of hand hygiene are being done by the health workers. So I would say that more than the sisters, the doctors will be the ones at the default when the 5 moments of hand hygiene are concerned. That when you go for examining the patient, you will do hand rub, but after examining the patient or after touching the patient's surrounding, that is the step which is most commonly missed. So we would want that these posters of hand hygiene and the 5 moments of hand hygiene should be kept in your ICU. And besides hand hygiene, the next important steps is that having a checklist for the insertion of various lines like UVC, UAC or PICC line insertions, where you follow the steps for hand hygiene. Initiate oral feedings as early as possible. The VLBW should be on full feeds by 1 week. The ELBW should be on full feeds by 2 weeks in your unit at all costs. And antibiotic stewardship, wherever it is not indicated, you don't start antibiotic. When you have started an antibiotic on a clinical suspicion, stop antibiotic as soon as possible. Only for the purpose that your PICC line is there, you should not continue antibiotics for 10 days. So stop antibiotics early whenever possible to prevent antibiotic resistance in your unit.
So coming back to our baby is now 48 hours old, but suddenly the perfusion decree was bad. That baby, the common terminology is baby is not looking good. Work of breathing has increased, FiO2 requirement has gone up. Can you just tell, we know that dope is there. Apart from that, what are the 3 possibilities? Yeah. Just 3 possibilities.
So not looking good at 48 hours, you have 3 usual suspects. First, as we all know, the commonest morbidity that we face in our NICU is sepsis. So you need to evaluate for sepsis, do a CBC, CRP, repeat blood culture, and initiate antibiotics if you're not on antibiotics, or escalate to a second line as per your unit protocol. So that's what sepsis. Secondly, you need to, at 48 hours, again, you need to look into PDA. PDA can cause havoc at this period of their life. So do a bedside echo, look into the PDA size, look into the LA, and initiate closure if the duct is significant. And thirdly, definitely being a preterm, you need to think about worsening of the RDS. Even though you have ventilated optimally or have administered surfactant initially, some of these babies might require second or repeated doses of surfactant. At many places 2 or to a maximum 3 doses of surfactant can be administered to these babies. So these are the 3 things that you need to think about at this point of time.
Dr. Murali, can you just very briefly tell about, because of the lack of time, can you just briefly tell about the PDA closure part?
Yes, and as this case, Dr. Nelby has elaborated, the PDA size was 1.5 millimeter and the LA was not much dilated, but still he preferred to give paracetamol. So, as the literature is there, a lot of evidence are there, still the practicing pediatricians or neonatologists are in 2 groups, whether to close the PDA or not to close the PDA. And the question and the answers are never ending. So if you happen to have a good echo by your bedside, and if you see your PDA size is more than 1.5, or LA or ratio is more than 1.4, and your cardiac output is more than 300 ml per kg per hour, you are dealing with a fairly moderate size PDA. So in that case, you have to treat that PDA either ways. You can have a pharmacological treatment, or you can have fluid restriction, that proper ventilation, and also you can try 1 or 2 doses of diuretics if you see that pulmonary edema is there, or the baby is going to have a pulmonary hemorrhage. So in that case, you can conservatively treat that case. And also in other cases, like if you deal with extreme temperature babies like less than 28 weeks or 26 weeks, majority of them will have large size PDA, and if the baby is on ventilator, and if you suddenly extubate the baby and give the baby on NIV or CPAP, there is chance that the PDA become more significant and the baby can bleed. And in that case, some clinicians try to close the PDA or look for echo and see the hemodynamic significance of the PDA and close it, try to close it before extubating the baby. And there is another early targeted therapy is there around babies around 28 weeks. You can do the echo in day 1 or day 2 itself and see whether the PDA is becoming significant, because there are clear-cut studies say that if you do a targeted echo on day 1 or day 2, you can clearly predict the significance of PDA before it becomes hemodynamically significant or before it becomes clinically relevant. As in this case, the baby had desaturation, tachycardia, all those things, and if you do this systematically, this point of echo on day 1 or day 2, systematically you can 20 to 48 hours before you can predict that the PDA can become problematic before the baby become clinically significant. So coming to that treatment part, pharmacological treatment part, there are mainly 3 drugs available, and people used to use indomethacin previously, and IV indomethacin was available, but now but to my best of knowledge, it is not available. Is it available? It's not available. And ibuprofen, people used to use it. That is 10 mg per kg, and day 1 and day 5 and day 2 and day 3. But now majority of the units are going to this using of paracetamol, because it is available in IV and otherwise oral preparations. And the preferred dose is 15 mg per kg, 6th hourly. Initially you can give for 3 days, and then you see whether the PD is closing or constricting or significance is reducing. And my feel is that you have to at least give for 5 days. Otherwise, if you stop it for 3 days, there is chance that the PDA again becoming hemodynamically significant is more. So that you can try these things, and suppose you are not attaining a closure of this PDA, you can try repeating another course and also another drug also. So majority of the PDA in preterm babies less than 32 weeks, only those cohort of patients you can try with this pharmacological closure. More than 32 weeks or 34 weeks, okay, you can try, but the chance of closure is very, very less. In that case, if it is becoming significant, baby is going to failure or pulmonary hemorrhage, you have to go for the rescue therapy like surgical ligation.
So, 2 things, as Murali was saying, PDA, the most common drug nowadays given is paracetamol. Lot of regimes are there, but most commonly used one is 3 days, do an echo. If it is completely closed, stop it there, otherwise give it for 5 days. Then some studies are saying anyway less than 6 days, if the PDA is there, paracetamol is the best. After 6 days, ibuprofen may be slightly better than paracetamol, but not statistically significant.
So coming to the adverse effects also, the indomethacin and ibuprofen, you have to see the blood counts and also renal function test. You have to monitor that, but paracetamol is relatively safe. You have to do in a baseline LFT. But there are some studies are coming up that these babies, when survive and grows up and up, they are having a high chance of having autism and other pervasive development disorders. So there is one point is also there.
So baby have survived this condition, whether it was sepsis, PD or whatever is there. So now the baby is growing up. So how will you monitor the growth and what are the importance of growth chart?
So first we need to know how a preterm baby grows. So they normally lose by around 10 to 15% of their body weight and reach their birth weight by 10 to 15 days if you are giving proper nutrition. Thereafter they gain by 15 to 20 grams per kg per day and head circumference growth of 0.5 centimeters to 1 centimeters per week and a length of 1 centimeters per week. So that is the normal growth which a preterm has. And the weight, in our unit we measure only alternate days so that you don't disturb the baby again and again every day. No change will happen if you don't take a weight one day. So weight of alternate days which we monitor in our unit, and we monitor the weight weekly. That's you see the weight gain over the last 1 week, how the weight is there in the last 1 week. And so you should know which growth charts to use. So when a baby is born, so the Fenton's chart, that is the intrauterine, you have 2 sets of charts, which is intrauterine growth charts and postnatal growth charts. So the one you see on your left is the intrauterine growth charts, which is being plotted, that is Fenton's chart, which is most commonly used. The one on the right is the new one, that is the Intergrowth 21, preterm postnatal follow-up studies. So what they did was that the preterms who were born in that study group, they were consecutively followed, prospectively followed for 64 weeks and their growth was plotted. Whereas Fenton's is a retrospective chart. So Fenton's actually should be used for only classifying the neonates as LG, SG or AGA, and postnatally follow-up should be done ideally by a preterm postnatal follow-up study. But there are many proponents here on both sides, so the debate can continue for the whole day. The proponents on the Fenton's will say that the neonates is 6 lakhs in Fenton, whereas that in the PPFS is only 200 neonates. That is the difference of the number of neonates. The Fenton has stood the test of time. From 2013 we have been using, Intergrowth has been there only for last 2 years. And the Intergrowth actually had all the healthy mothers. It eliminated the mothers who were small, less than 152 centimeter height, or the vegetarian mothers. Whereas in India, you have the average height of a female is the same as mine, that is 154 centimeter, and the female, 1/3 of the people are vegetarian. So will this chart cater to our population? Although there were neonates from, there were mothers from India in the PPF Intergrowth study, but still we have that doubt whether it will cater to our population because of this strict criteria. The most important thing, I feel that the resistance towards PPFS, our resistance, even my resistance, is the test of time. We have been using from our old days plotting on Fenton's, but we are having a difficulty to shift to PPFS as more and more medical colleges and more units will start using PPFS. Probably it will come into, because it is the only true postnatal chart when you want to consider the postnatal growth of the neonate. So this neonate, which we see that there is a slight growth faltering and it is crossing centiles below the centiles. So this new child may have been said to be growth faltering in the Fenton's when plotted in PPFS. So they say that 1 in 5 extra uterine growth restriction is actually coming to be normal in Fenton's. So we may be worried that the baby is not growing well, but it is because of the faulty chart that you are using. It is probably not related to the growth of the baby.
Dr. Binu, Vishnu and Murali, which chart you will prefer? Just personal one. Fenton.
Yeah, Fenton.
We do use Fenton's.
So
what is important is that the curve should be followed. That is not fall into that gaps. So
it may be my personal opinion, but Fenton is the ideal thing, and this Intergrowth chart is the practical what is happening. We are just taking the reflection of what is happening.
So AAP in 2009 told that the newborn outside should grow as the same way as a fetus should grow inside. That is the same reason that I am also using it. But we should understand that these are size at birth charts. They are not postnatal. Somebody has done the 2 to 3 years of study doing a prospective study. This is a retrospective study. That is a prospective study. They have meticulously enrolled mothers ultrasound, they have radiologically followed the mothers in the antenatal period. Postnatally, they have followed the aggressive nutrition, parental nutrition in the neonates, and then followed the growth of this neonate. So you cannot discard the intergrowth, whatever be the reason. The intergrowth are the two postnatal charts. There is a resistance from our side, and we can advocate that the number of neonates, especially the units which are handling very preterm neonates, the number of neonates below 32 weeks was only 28 in case of PPFS. So that is the problem. So unless and until a very large study enrolling large number of neonates, enrolling more neonates from India, prospectively followed, comes up with a growth chart, we may not shift to PPFS.
For the time being, I think Fendon will be the ideal for our. Now we'll go high risk. We'll go to, we are not going into the details of the baby. The baby is about to be discharged. And what will you follow up in the immediate neonatal period?
Time zone.
Yeah, last time.
I think this is the last two slides. I'll go through it fast. So this just for academic purpose. Hearing charts, there are a lot of things about OA, automated BERA and all. The screening test of OA is most commonly done. AABR is preferable, the automated BERA. That is also not definitive, but it's preferable to OA. And preterms, you preferably do it at around 34 weeks. For units who are looking at extreme preterms, wait till 34 weeks for the screening test. And confirmation, if you get this negative, you do confirmation test at 3 months on the definitive BERA. So this is how you should go about. Now the thyroid screening is also, we all know that core TSH is done. If it's not within 72 hours, you get a value of T4 TSH and repeat by 7 days for borderline values. And for extreme preterms, you can repeat at 2 weeks and even at 6 weeks. The cutoffs are like if it's more than 2 weeks, the cutoff is 10, and if it's less than 2 weeks, the cutoff is 20 for TSH. I hope that is clear. And regarding the ROP, there is the American Academy says any baby born less than 28 weeks, you do the ROP at 30 weeks, whereas NNF says at 3 weeks, you can screen for babies less than 28 weeks. And all other babies you can screen by 4 weeks. And repeat screening if necessary, 1 to 2 weekly. The neurosonograms, the earlier cutoff was 32 weeks and 1.5 kg, but now it's coming up to 34 weeks and 2 kgs, and also babies with risk factors like ventilation, sick babies. So anything less than 2 kilos, you can do neurosonogram, and timing should be within 72 hours, 1 to 2 weeks for early PVL, 3 to 4 weeks for cystic PVL, and a term-based station. Now the thing with neurosonogram is, those who are looking into extreme preterms, the bleeding can happen at any time. So if you are treating a 24-25 week baby, and if you get grade 4 bleed, you have to discuss with the parents about the prognosis. So during rounds itself, most of us have a practice of doing neurosonograms and then seeing whether anything new has happened. So these are the guidelines for documentation purpose. For practical management, you have to do more frequent if it is extreme preterm. I think that covers it.
So one or two things regarding this, if you are taking care of a preterm babies, always OA is not much helpful because it tends to miss auditory dyssynchrony. That is transmission of sound from the cochlea to the nerves. So it will miss auditory dyssynchrony. So either ABR as a screening or BERA should be done for preterm babies less than 34 weeks. Then if we are treating a baby less than 32 weeks or 1.5 kg, always repeat thyroid function test at 2 weeks, 6 weeks and 10 weeks. Late hypothyroidism may be there, or late rise of TSH value which will be missed will be there. And last thing is, you have to save yourself. Don't ever miss ROP. So get a written consent from the parents that the importance of ROP is told to me, and I will come and get it signed and mention about ROP in the discharge summary, because whatever cases are running about against the neonatologists, almost 90% are for ROP. So never miss ROP. With that slide, we'll end our panel discussion. Thank you.
I now Nelby to present a memento to our panelists. I now request Dr. Balchandar to present a memento to our moderator, Dr. Nelby George. We have come to the end of our academic session.